Diabetes mellitus foot, diabetic foot V13. A 55-year-old man with poorly controlled diabetes mellitus presents to your clinic with a hot, swollen foot. How will you manage? So I will take a history, duration of symptoms, any trauma, any previous infection, neuropathy, any ulcers. Examine him predominantly different between the Charcot's neuropathy and foot sepsis. Assess for neuropathy, peripheral disease. Admit for multidisciplinary foot team. Seek acute medical advice from diabetic team. Swab the area. Obtain podiatrist opinion to offload the foot. Arrange for urgent imaging to explore underlying collection by MRI, and urgent surgical treatment of the foot sepsis is required. The patient had a collection over the dorsum of his forefoot that has been drained and now is systemically well. What is your ongoing management plan? So he needs to continue with the broad spectrum antibiotics, unless sensitivity is available, and offload the foot, conduct regular wound review and blood when necessary, review and optimize the diabetes control, and offer patient education about foot care, and request MRI and arterial duplex. The wound becomes necrotic at the edges. The duplex shows a stenosis of the mid SFA and heavily calcified infrageniculate vessel with likely multi-level disease. How would you proceed? So arrange an angiogram and angioplasty to treat the SFA stenosis and attempt to treat the infrageniculate disease and assess the runoffs. Some data are showing improved patency rates of treatment of short focal infrageniculate lesions by drug collateral. What is the blood supply of the foot? So anterior tibial artery, posterior tibial artery, and peroneal artery. Anterior tibial artery can be palpable as a dorsalis pedis artery, and posterior tibial artery behind the medial malleolus and peroneal artery. Following revascularization, the wound improves. MRI shows no further collections, but osteomyelitis in second and third metatarsal. What is your discharge plan for this patient? So continue long course antibiotics and offloading. Follow up in the multidisciplinary foot clinic to monitor the wound for antibiotic therapy and to ensure continued best medical therapy. Surveillance of the bypass graft if appropriate. And what are the indications for primary amputation in this patient's? Extensive soft tissue destruction with non-viable foot, extensive infection, no vascular reconstruction possible, and ascending soft tissue necrosis. No vascular reconstruction possible and ascending soft tissue necrosis. How would your revascularization plan change if angiography showed mild disease above the knee but heavily calcified and multiple stenosis in all the three coronal vessels? The anterior tibial artery runs to the foot. There are three options: endovascular, surgical, and hybrid procedures. Revascularization should follow the concept of angiosome, and total revascularization plan should be implemented in the setting of significant tissue loss. Thank you.